Doctor, please accept the request to be promoted to panelist section.
Previously, it was not started only.
Dr. Ranjith, can you hear me?
Yeah, I think you started the meeting now only. I can hear you now. Can
No,
you hear me?
doctor, it was started at 4 p.m.
But I was trying to join. I could not.
Doctor, actually, you were using the attendee link and not the panelist.
Oh, okay. Okay. Now I got it. Yeah, I can see.
So, Dr. Ranjith, you are one of the speakers for today?
Yeah.
Okay, can you please try sharing your screen?
Just a second. Can you see my screens now?
Yes, please put in slideshow.
Yeah.
Yeah, try to move the slides. Perfect, you can stop sharing.
And how is my audio?
It's perfect. And the video is also playing. Video is playing with audio.
Thank you. Thank you very much. I will keep muted. Let me know once the
Doctor, is Dr. Kumon the doctor that has joined? Is he the other speaker?
What?
This is Dr. Murugan. I think I just joined in and it's my wife's name that is in there through. So I don't know how to change that one.
Doctor, what's your name? I'll change it.
Dr. Murugan.
Okay, can you please try sharing your screen as also you are also the speaker?
Yeah, we do that now. Just 1 minute.
Yeah, we can see it. Just put in slideshow.
Yeah, just clicking on it. No. Can you see it?
Perfect, doctor. Perfect. Just try moving the slides. Perfect, doctor. You can stop sharing the screen and share out after the introduction.
Okay, just check. Is that okay?
Yeah.
It's a little bit slow. Sorry. Let's see if I can. Just not in the right position, I think.
Hello. Hi, Dr. Velmurugan. Hi, Dr. Ranjith. Hi.
Trying to.
Can you hear me?
Can you see me wave my hands? Can you see me clearly? Is there a problem?
Yeah, I can see you clearly, but video konjam, it's getting interrupted, the voice and video.
Okay.
Dr. Velmurugan, can you hear me? I think you should stop your video. That is why you're. Dr. Madhuswini,
Yes,
will you be sharing your screen?
Hello,
Yeah, I will be sharing my screen. Yes. Yeah.
Okay. Can you try sharing it once?
Yeah, I will. 1 second. Let me just choose the right one. Is it okay? Can you see it?
Just put in slideshow, please.
Now?
Perfect. Just try moving. Yes. Perfect. You can stop sharing the screen now.
Okay, thank you.
Thank you. So we'll start exactly in 3 minutes.
So good evening, sir. Good evening, sir.
Yeah.
Yes, sir.
Good afternoon, Rajendran. Good afternoon.
Good afternoon, sir.
Good afternoon, sir.
Yes, sir. Good afternoon, sir.
Good afternoon, Dr. Velmurugan.
Velmurugan, good afternoon.
Hello.
Rajendran, Sini varara? Sini?
Sir, தெரியலைங்க சார்.
Phone பண்ணிடுவோமா? கேப்பமா? எங்க இருக்காருன்னு தெரியல. எனக்கு மீட்டிங் ஏதோ இருக்கு, நாங்க ஹை லெவல் மீட்டிங், கோவிட் பேண்டமிக், இந்த லாக்டவுன் பத்தி ஏதோ மீட்டிங் இருக்கு, நாங்க கேட்டுறேன். Manaswini is joined. Welcome, madam. Dr. Manaswini.
Hello, sir. Hi, எப்படி இருக்கீங்க?
நல்லா இருக்கேன். Happy to learn, see you and learn from you a lot.
Thank you,
I
sir.
think second such awareness program. Really, we are looking forward to learn many things. This is only an tip of the iceberg. Really, many things need to be explored under your leadership. Sini, login பண்ணுங்க. மனஸ்வினி வந்தாச்சு, வேல்முருகன் வந்துட்டாரு. Speak. ராஜேந்திரன் சொல்லிட்டுமா? அப்போ ஸ்பீக்கர்ல போட்டுட்டுமா? ஓகே, ராஜேந்திரன், ஸ்ரீனிவாசன் பேசிருங்க. இந்தாங்க, பேசுங்க. Please.
Rajendran, all the best for the new innovative SMA, treating SMA children using Resdiplam. And I have ended up in a meeting, Rajendran. So please carry on with that. My wishes and my support and everything will be there for the program. In fact, I am trying for one child in my own ward. Unfortunately, the child died. I made all arrangements for this one also, but unfortunately, I could not succeed. Anyway, in future, any children comes, we'll try for that also. Through NRHM under rare genetic disorders, we can get funds for this in treating this SMA. Thank you. Soms.
Thank you very much, sir. We are indeed very thankful to you for bringing out this most important awareness program on SMA. When we were students, we do not know how to go, but we are stuck with. Now the patients have really great opening, and thanks for all. Thank you very much.
Thank you. Sorry, I'm in a meeting. I'll call you back later.
Thank you.
Doctors, please start the session. It's 4:30.
Dr. Ranjith, welcome.
Dr. Ranjith sir, welcome, sir.
Yes, sir. Thank you, sir. Thank you very much, sir.
Murugan, welcome.
Hi, Rajendran. Thanks.
Yeah, but Murugan, my batchmate, classmate.
Oh, great. Oh, nice. Oh, nice. So nice. Murugan looks really young, na? President has joined. I think we can start, sir, without wasting time. Yeah. Welcome, Raj. Welcome, Ismail.
Good evening. Good evening. Good evening.
Good evening.
Right, sir.
Yeah, I will start the meeting. Yeah.
Yes.
Good evening to everybody. On behalf of IAP TNC, I welcome our South Zone Vice President, Dr. Swamsagar, our Dynamic President, Dr. Ismail sir, our today's speaker, Dr. S. Murugan, and Dr. Ranjith, and Manaswini Sivaramakrishnan, and the Roach from Roach, Mr. Chandramouli. So, in behalf of IAP TNC, I welcome one and all once again. First, we'll start with our presidential address, Dr. Ismail sir.
Yeah, good evening, all of you. Rajendran, thank you. South Zone Vice President, Dr. Somshekar. And today, I think the moderator has not joined, Sri. Rajendran?
Yes, Dr. Ranjith joined and Dr. Murugan joined. Yeah, everybody joined.
Okay. And today's speaker and my good friend, Dr. Murugan, Dr. Ranjith, and Manaswini Sivaramakrishnan. And of course, it is an important topic today. The neurologically, the spinal muscular atrophy plays a vital role, and it is the talk of the town now, the treatment modality. I think lots, it hits the headlines in the papers, and of course, it's a debate going on about this disease. And of course, we welcome all the speakers, and we wish a happy learning for all. Thank you.
Thank you, sir, for your nice words. Now I welcome our South Zone Vice President, Dr. Swamsagar. He is a EB member as well as South Zone, Karnataka, Tamil Nadu, and Kerala, 3 zones. He is the Vice President. And I welcome sir to give a guest of honor address and inaugurate the Spinal Muscular Atrophy Awareness Symposium.
Thank you very much, my dear Rajendran, and beloved and respected President of the IAP GNSC, my friend Dr. Ismail, and dynamic Secretary, Honorary Secretary Dr. Rajendran, and the Treasurer Dr. Gopal Subramaniam. Indeed, it's a very pleasant day today. We all assembled here on the eve of a Onam. So happy Onam to all of you. And this particular topic, awareness on spinal muscular dystrophy, is the need of the hour. As President Ismail has said, when we were postgraduates, a case comes, like we were all stuck and we do not know how to proceed with. So we just simply, that the gate is closed. But now there are a lot of openings here to start and create an awareness. I think here are the experts. Dr. Srinivasan in absentia, he has just delivered his message that is held up now. He has been coordinating the fund, everything to take care of the poor children affected with the SMA in terms of fund with the Roche company. And the first of its kind, I think, in Tamil Nadu. I thank Dr. Manaswini Sivaramakrishnan. She is son of her own soil, although she is from place where she's been coordinating. I'm happy to listen to her for the second time. And I also thank Dr. Ranjith Kumar and Velmurugan. Is as Dr. Rajendran has said, he's the friend and the classmate of Dr. Rajendran. And without much wasting time, there are many viewers here today have joined, and looking forward to listen and learn to many things, I think unexplored things in the field of spinal muscular dystrophy and way forward. And thank you very much for the opportunity given. And once again, I thank IAP TNSC and inaugurate the session for the happy learning by all the viewers. Thank you very much for the opportunity. Thank you.
Yeah, thank you, sir. And now I welcome Dr. Chandramouli. Dr. Chandramouli?
Yes, sir.
You want to tell any few words you can after this?
So first and foremost, I would like to thank your organization, IAP, from Tamil Nadu chapter, and of course the central team, and for giving us an opportunity to have this particular talk on symposium of spinal atrophy. So this is a very important topic, which is very much seen. And without wasting, and in fact, I would like to thank the secretary, yourself, Dr. Rajendran, of course, Dr. Somasika sir, and Dr. Ismail, and in fact the speakers, Dr. Ranjith, Dr. Velmurugan, for giving that time actually, and of course Dr. Manasini from Roche, she's right now at Basel, Switzerland. And I thank all the members, and in fact our doctor is also joined, Dr. Milan. So thank you very much, and happy learning for all of us. Thank you, sir.
Yeah, thank you. Now we will go for a topic, and now I welcome Dr. Ranjith Kumar Manokaran. He is currently Associate Professor, Department of Neurology, Sri
Rajendra, we can also ask Milan to just give his felicitation, because it's a Roche doctor, the panelist. Milan
Yeah.
Kose.
Yes. Good evening, doctors. First of all, happy Onam. On this auspicious occasion, thanks for giving us this opportunity. Yeah, can you see? Yeah. So, thanks for giving me this opportunity, and basically Roche this opportunity to bring, to basically sponsor this particular session. Yes, spinal muscular atrophy has been the talk of the town. A lot more developments happening. Now no longer this is an uncurable disorder, and that is what we would like to highlight on this particular platform. And I hope that by the end of this session, we have a lot more knowledge, and we are a lot more wiser. Thanks. Over to you, doctors. Thank you.
Yeah, thank you, Dr. Milan. Now I welcome Dr. Ranjith Kumar Manokaran. He is currently Associate Professor of Pediatrics and Neurology, and also consultant pediatric neurologist, SRMC, and he has done his MD at AIMS and MD Pediatric Neurology at AIMS, New Delhi. And his area of specialization is pediatric neurology and epileptology. And he is a winner of a prestigious award from Madras Medical College. And he has more than 20 publications. Now I welcome our today's speaker, Dr. Ranjith Kumar, to talk on genetics and recurrence and prevention of SMA. Dr. Ranjith, you can proceed. Yeah, you can see the slide. Yeah, no problem. Yeah.
Good afternoon. Previous slide.
Yeah, proceed, please.
Good afternoon, everybody. Am I audible, sir?
Yeah, audible. Yeah. Audible.
Yeah. Thank you very much, sir, for your wonderful and kind words. I would like to take this opportunity to thank IAP Tamil Nadu chapter for giving me this opportunity, and also Roche to deliver this talk. So, previous slide. It's not moving. I think first
we have to log out and log in. Sometimes we network issues log in something. Okay. Network issues.
Doctor, just tap on the screen. No, tap on the screen once. Tap on it and then move the slides.
the slide is not moving.
You need to tap on it. Yeah.
First slide, yeah. Okay, so now we are set. So the topic for today's discussion, the first topic is spinal muscular atrophy, genetic diagnosis and the recurrence risks. So it is very important to understand the genetics and the recurrence risks of spinal muscular atrophy before we proceed to the clinical features and the novel treatment options, because the entire the basis of novel treatment options are based on the genetics of SMA. So it is imperative that we learn the genetics. So why should we learn about SMA in this discussion? Because this is the hot topic of the town. So we know there is a general kind of opinion that many pediatric neurological disorders are not curable, but the SMA has caught the attention of the mainstream media. You can see it is coming up in the first page in newspapers and media's hot news because of the novel treatment options and exorbitantly costly medicines. So it is the need of the hour for pediatricians to understand what are those drug options and what is the future of children with SMA in this era. Okay, so let's start with this clinical scenario. We have a 9-month-old baby, first born of a consanguineous marriage, presented with predominant motor delay and floppiness. CPK is mildly elevated. Thyroid profile is normal. So the doctor has advised to do a clinical exome and mitochondrial gene sequencing. The report came as negative. So he was in a fix. So how do we interpret this result? Do we label this as something non-genetic, or how do we take it forward? So we need to understand what is this, what is the basics to be able to interpret this result and how to move forward. So we'll come back to this scenario. And so this was a baby with typical tongue fasciculations. You can see the scintillating tongue and the bright and alert faces. And this is the posture of the baby, the typically described frog-like posture with hypotonic baby. So SMA affects patients of all ages across the spectrum with a broad range of disease severity. So it can be classified based on the onset of symptoms, the life expectancy, and the motor function. The previous eponymic classification, that is Kugelberg-Wellander disease, Wernicke-Hoffmann disease, all these terminologies are nowadays out. So we are now more into the phenotypic classification, that is type 0, type 1, type 2, type 3, type 4. Type 0 is the prenatal onset, where there is a very early onset starting in utero or less than 1 month of age, and the baby dies very early. Type 2, type 1, that is type 0. Type 1 is 0 to 2 months, lifespan is onset, lifespan is very limited, they never sit, they are non-sitters. Type 2 is 3 to 17 months of onset, intermediate type. They will be able to sit. So they are sitters, but they cannot stand. Type 3 is onset beyond 18 months of age. They may have a normal expectancy, but they will have walking difficulties. They will need a lot of assistance. Type 4 is typical adult onset with late onset, and they may have a normal life expectancy. So this is a spectrum of phenotypic expression of SMA. So why does such spectrum occurs, although the genetics and the gene causing remain same? Let's move further. So this is the crux of today's presentation. This is the genetic basis of the disease. We have two genes, SMN1 and SMN2. They are two almost identical genes located on chromosome 5q13. So this is the chromosome 5. This is 5p and this is 5q. Q is a long arm. And we have two genes. One is SMN2, another is SMN1. SMN2 is located towards the centromeric end. SMN1 is located towards the telomeric end. And these two genes are exactly identical, except for the difference of just 5 nucleotides. And these are not the only two genes in that region. We have other genes which do modify the expression of these genes. For example, NAIP is one other significant gene, neuronal apoptosis inhibitor protein. So these SMN2 and SMN1 influence the disease process in SMA. How does that happen? SMN1 gene is the main source of a functional protein called SMN protein. The SMN is survival motor neuron. So that protein level is required in a high quantity in the anterior horn cells motor neurons to maintain the integrity of that anterior horn cell. If due to any reason this SMN protein is not available in a good quantity, these cells undergo progressive degeneration. That is how the disease manifests. So in healthy individuals, two genes which code for SMN protein are there, SMN1 and SMN2. There is a difference only in the C2T mutation, which affects the splicing of the functional protein. So SMN1 gets transcribed to pre-mRNA, which gets spliced to mRNA, and then the protein is produced. So SMN1 produces the fully functional SMN protein. Whereas on the SMN2, when there is a change in the C2T, it leads to a protein which is 90% unstable, labeled as SMN delta 7, which is rapidly degraded and is no longer available for our maintenance of anterior horn cells. It does produce 10% of functional protein, but that is not sufficient enough. But because the SMN1 gene is intact, the patient or the healthy individual will not have any manifestation. So this is the normal human genetic physiology which happens. If due to some reason there is a mutation in the SMN1 gene, which results in reduced level of the functional protein of SMN1, the SMN2 will not be able to supplement that amount of functional protein. So that will lead to low levels of SMN protein in the anterior horn cell, leading to disease progression. So SMA happens because of mutation in SMN1 gene and not in SMN2 gene. So these mutations can be a point mutation, or a point mutations means a single nucleotide change, or it could be a deletion of the entire exon. The commonest exon which gets deleted is the exon 7. So this is the exon which gets deleted. So it could be an exon 7 deletion or even a point mutation in the coding region of SMN1 gene, which leads to the insufficient levels of SMN protein. And this disease is an autosomal recessive disease because it's an autosomal recessive. That means both the copies of SMN1 should have deletion or point mutation for the disease to manifest. If the patient is in a heterozygous state due to a mutation or deletion in the SMN1 gene, that will not manifest as a disease. The patient will be called as the individual will be called as a carrier. So both the copies of SMN1 need to have the mutation for the phenotype to be expressed. SMN2 is not necessary in unaffected individuals, as we have seen. So if a patient has a mutation only in SMN2 gene, otherwise there are two intact copies of SMN1, that is not SMA. If the patient has mutation only in exon 8 of SMN1 gene, there is intact exon 7 without a point mutation deletion, that is also not an SMA. So these are two misconceptions which commonly happen during interpretation of an SMA genetic report. So the therapeutic approaches which we are going to discuss in the subsequent talks are entirely based on this concept of SMN1 and SMN2, the requirement to increase the SMN protein levels. So those who are having a single mutated gene of SMN1 are called carriers. The carrier frequency of SMA is quite high in a general population. I will show you in subsequent slide the exact population according to the ethnic populations, but generally it is believed to be 1 in 45. 1 in 45 is quite high. So we expect the disease frequency to be very high. But due to some reasons, the disease frequency is not that high, although it is 1 in 10,000 to 20,000. That is because the prenatal type of SMA, that is SMA type 0, get aborted or death in utero. They may not be manifesting in the general population. That could be the one reason why the disease frequency is not that commensurate with the carrier frequency in the population. So because we have told it's autosomal recessive conditions, if two carriers come together and consummate the marriage, there is a 25% chance of having a child with an autosomal recessive condition. 25% of the chance of the child being a carrier. 50% chance of the child being a carrier, and the 25% of percentage of chance of having a normal child without carrier status or affected status. Okay, so what is the disease progression? So genetic mutation leads to SMN1 gene deletion or a mutation, which leads to insufficient levels of SMN functional protein, degeneration of alpha motor neurons, and that leads to loss of motor function. It is not the end of the road. Even the loss of motor function leads to secondary disease complications ranging from scoliosis, respiratory infections, chest deformities, difficulty in sleep and nutrition, and they may require need for respiratory, orthopedic, and mobility support. And overall, it also leads to a reduced quality of life. Then how do the spectrum of happens? That is because of the SMN2 gene. Although there is a deletion or exon mutation in the SMN1 gene, the disease manifestation is modified by the number of copies of SMN2 gene. Because we saw in the previous slide, SMN2 gene can still produce 10% of functional protein. So if you have more and more copies of SMN2, you will be having more and more levels of functional protein in the system. So higher the number of SMN2 protein, better is the phenotype situation in the SMA disease. So it's, in other words, the number of SMN2 is inversely related to the disease severity. So let's come to another scenario. A 2-year-old child presented with predominant developmental delay, consanguinity is present, has a mixed hypotonia. Genetic testing reveals homozygous deletion of SMN2 with intact SMN1. So how do we interpret? So we label this patient as SMA, yes or no. The participants can type in the chat box. Ms. Tanvi, is there a chance of seeing the responses in the chat box? Okay, so this is not SMA. So many times the clinician may see the word homozygous deletion and get carried away with words. So it is SMN2, not SMN1. So they do not have SMA. Rather, they may have a higher risk of amyotrophic lateral sclerosis, ALS, in later lifehood. It is not related to the causation of SMA. Okay. So this is another important slide to understand the genotype and phenotype correlation. So this is SMA 0, 1, 2, 3, 3A, 3B, and 4. You can see the number frequency of SMN copies. So you see SMN2 copies. In SMA 0, it may be 0%. Number of, for example, SMA type 1, 73% have 1 copy. In SMA type 2, 78% of 2 copies. In type 3A, 50% of 2 copies. So type 3B, 60% of 2 copies. In type 4, 75% of 2 copies. So increasing number of SMN2 copies reduces the disease severity. And that number of copies is also required for deciding the novel treatment options, which my subsequent speakers will be dealing with. Okay, so how do we make a diagnosis of SMA in a child who we are suspecting SMA? So the first step in diagnosis of SMA is to confirm the mutation. So we need to identify the SMN1 homozygous deletion test via a real-time PCR or a MLPA. So the 95% of SMA 5Q cases have a deletion of exon 7. Clinical exome sequencing is a test which is based on the next generation sequencing technology, which may miss deletions. So it is a test of choice for point mutations. So for SMA diagnosis, clinical exome is not the right choice. We need to perform a multiplex ligand probe amplification, also called MLPA, or a real-time PCR. In this test, if you find both the copies of SMN1 gene deleted, exon 7, then you can label the patient as having SMA. If the gene test is negative for deletion, further laboratory and electrophysiological tests are performed for confirmation of diagnosis. In 5% of cases of SMA, you may have other types of mutations like point mutations or splice site mutations, which may not be picked up on the MLPA for exon 7 deletion study. So in that situation, we may have to go for sequencing of SMN1 gene, which can pick up the point mutations. So this is what I described in the previous slide. The methods used for diagnosis of SMA is quantitative PCR or MLPA. We commonly do MLPA. It can be a diagnostic test for a suspected patient or a carrier test or a prenatal test. In SMN1, 95% can be identified by this type of targeted genetic analysis. 5% of cases may be missed in this analysis that may be diagnosed only on a sequencing analysis. Okay, so this is the algorithm. You suspect a patient with SMA. You pick up homozygous deletion, that becomes SMA. If you don't pick up a homozygous deletion of SMN1, then you need to repeat your physical examination. You find evidence for axonal neuropathy or demyelination. In the previous pre-genetic era, we were proceeding with muscle biopsies and nerve biopsies to pick up muscular dystrophies or myopathies. In uncommon features of SMA, but there is a neurogenic EMG on EMG, but the normal CPK, you can think of other disorders. If there is a proximal weakness, proximal to distal weakness gradient, normal CPK neurogenic pattern, and you do the SMN1 copy count. If you find 2 copies of SMN1 intact, it is also other neurological other neuron disorder. It is not an SMA. If you find only 1 copy intact, the other copy only 1 copy is intact, another copy is deleted, then you perform SMN1 mutation analysis of the point mutations, so which can confirm the diagnosis of SMA gene. If you don't have any mutation, then you have to think of other diagnosis. At the outset, if you find a homozygous deletion of SMN1 exon 7 homozygous deletion, that confirms the diagnosis of SMA. This is the commonest diagnosis which we make in 95% of cases. This is the pathway which may be required only in a 5% of cases. Okay, so now I am introducing you to the concept of 5Q and non-5Q. So far, we have been dealing with a type of SMA called 5Q SMA. By and large, when we refer to SMA for the practical purpose, it refers to 5Q SMA. But the term SMA refers to a broader set of neuromuscular disorders which manifest with neurogenic atrophy, having proximal and distal involvement of motor neuron loss in the spinal cord, muscle weakness, and atrophy. There are so many genes which are now being discovered because of the advent of the next generation sequencing. These set of disorders are called non-5Q disorders. That means that gene defect is not at the chromosome 5Q level. So the common entities could be an X-linked SMA or a mitochondrial dysfunction, pontocerebellar hyperplasia. I would try, and there is an entity called hereditary distal motor neuropathy. The one catchy disease is SMOD, that is SMA with respiratory, diaphragmatic and respiratory involvement. That is very peculiar to mimic exactly like SMA, very early onset, and they may have significant respiratory insufficiency requiring ventilatory requirement. Recently, we had a case of SMOD, which had a diaphragmatic ventilation and requiring prolonged ventilation. So coming to case scenario 3, this is a non-consanguineous couple who comes for genetic counseling. Their first child had succumbed due to genetically proven SMA type 1, homozygous exon 7 deletion in SMN1 gene. So we proceeded with the carrier testing for both the parents for risk assessment in subsequent pregnancy. The report came as father is a carrier, mother is not a carrier. They had been proven to have a genetically proven baby who died of homozygous deletion. How do we explain the scenario? We have the father is a carrier, mother is not a carrier. So there is some kind of a discrepancy here. Let's delve further into the genetics of SMA. So we all know if both the parents of carriers, we have a 25% chance of a healthy child, 50% chance of a carrier, and 25% chance of a child, a totally normal, a totally affected child. But sometimes you may not have carrier status in one parent, but still that can be explained by 4% of carriers have 2 copies of SMN1 on a single chromosome. We know each chromosome has 1 copy. Sometimes you may have 2 copies on 1 chromosome and the other chromosome does not have a single copy. If that chromosome gets inherited in the child, that patient may have the person may inherit SMA. So when you do a gene dosage analysis for this 4% of carrier, it will show us having 2 normal copies. It won't show us a carrier. So that is one possible explanation. Another possible explanation is sometimes there's a point mutation which happens de novo in the gene which is inherited either from the father or mother who is not a carrier, and the other father or the other spouse is a carrier of the gene. So de novo mutation can also explain new occurrence of SMA in around 2% of patients where only one parent is carrier. So both the parents need not be a carrier to beget a baby with SMA. So this is the carrier frequency in the general population. It's very high in Arab, Asian, and Indian populations, up to 1 in 17 Indian population. It is slightly lower in Black and Hispanic population. So if you see at the Asian Indian, it's roughly 1:70. And the estimated disease frequency, these are Harvey and Weinberg based on the population, father do of population genetics. So the estimated incidence based on the Hardy-Weinberg equation is 1:10,000. So that is a high frequency for a genetic disorder, that too something which is lethal like SMA.
Hello, Dr. Ranjith. I think hello, Dr. Ranjith.
ஒரு கனெக்டிவிட்டி போயிடுச்சுன்னு நினைக்கிறேன்.
Sir, I'm calling him. Sir.
Yeah.
He's joining back. I think there has been some connectivity problems. So he's joining back in another minute or so.
Okay.
Yeah, I am back. Sorry for the interruption. We got disconnected. I will share the screen again. Can we see the screen again?
Yeah, please.
Sorry for the interruption. Okay, so we are coming into the most important aspect of discussion, that is genetic counseling. Genetic counseling is essential for anybody, any couple who already had a child previously affected with SMA, because they need to understand how it is possible to prevent. And with the advent of novel therapies, even if there is a chance of any, so the parents have the right to take their own decision. So the ideal time to do a genetic counseling is prenatal, is the right time. So we can explain them about the genetic risks involved, the clarification of carrier status, and the availability of a genetic testing. So this should involve the young adults who are affected, or they could be carriers, or at the risk of being a carrier. So coming back to the original slide, so a 9-month-old baby who had a consanguineous from a consanguineous couple, predominant motor delay, CPK mildly elevated, thyroid normal, clinical exome and mitochondrial gene sequencing is negative. So how do you interpret this result? This is basically, this test has not picked up that exon 7 deletion. This child should actually undergo an MLPA to diagnose the SMA. So the main message is we need to do the right genetic test to be able to diagnose the right condition. So my take-home message is understanding the genetics of SMA is of paramount importance in this era of genetic therapy and prenatal risk and assessment and prevention. These are my contact details, and this is SMA Awareness Month. Thank you, IAP and Roche, for giving me this opportunity. I am willing to take any questions at any stage.
Yeah, thank you, Dr. Ranjith. Now we'll keep the question and answer session last. Now I welcome Dr. Velmurugan. He's a pediatric neurologist, GKNM Hospital, to talk on
any other cases.
Yeah. Dr. Velmurugan.
I'm just starting now.
Can you hear me?
Yeah, I can hear you.
You'll talk on the clinical diagnosis of SMA today.
Yeah. Okay, here we go.
Yeah, we can see your slide. Yeah.
Doctor, just click on one slide to move it. Just click on it.
Dr. Velmurugan, voice is breaking.
Just Coimbatore, and is it clear?
Yes.
Hello?
Yeah.
Right. Okay. Thanks, Ranjith. That was a very clear description about what we really need to know about the genetics. So the SMA, one of the main part of SMA is the genetics. And whatever you might talk about, without genetics, there is nothing. It's like Duchenne muscular dystrophy, it is CK. So similarly, for SMA, it is the genetics. So I need to talk a little bit about genetics just to touch upon it, and then it will make sense of whatever I'm saying. So I'm going to just get on with that. So I'll go through the history, features, and the management, and then summarize with some take-home points. Now here, if you look at it, I've said an incidence of 1 in 6,000 to 1 in 10,000, while Ranjith said it's between 10,000 to 20,000. And we need to consider this very clearly, because this 1 in 6,000 to 1 in 10,000 comes from German studies and Netherlands studies, where they are looking for it and then picking out all those ones with SMA type 0, where they would have died prenatally, as well as the ones who would have died soon after birth. So people are really looking out for it and then carefully documenting them. So you do find them to be higher. The male to female ratio is 2:1, and 95%, as Ranjith said, it was SMA deletion or mutation. And most of them will be coming into the SMA type 1 to 3. The later onset one, much on this time, and just to mention, are from parents. So it's always better to discuss with the geneticist if we are into that situation. So this is the alpha motor neuron, which is affected. I hope you can see the map. And so SMA is a neurodegenerative condition, and it affects the alpha motor neurons. And so the alpha motor neuron, what it does is inhibition. So if this is affected, what you get is fasciculation. So that's what Dr. Ranjith was demonstrating. And so the degeneration of the cells in the alpha motor neuron in the anterior horn cells, and that is what is causing the problem. Okay, but then I come to it further on. It's the DNA, and then from here, and this is called the survival motor neuron protein, which Ranjith had gone through, and I will just move on into the next slide. Now, this is just a simple, straightforward one in an unaffected person that produces the functional SMN protein, and very little by the SMN2, which is nearly something like 10%. And if you have the deletion, then you have only mostly non-functional SMN protein is produced. So this causes the problem with not enough SMN
Dr. Velmurugan, your voice is breaking.
So what is so important about the survival motor neuron protein? It is not just a neuron. It's hear me better now. I'm getting closer.
Yeah,
Hello?
better. Yeah, better.
Yeah. So it is survival motor neuron protein is like a husband who cleans the house properly, keeps it all clean, throws away the unnecessary things. So that is what it does in cell maintenance. RNA splicing, mitochondrial homeostasis, endocytosis, and the cytoskeleton, ubiquitination. So that means just attaching it to ubiquitin and then taking it there, cleaning it up, and autophagy, cleaning it up, RNA transportation. So all these are done by the survival motor neuron protein, which is present in all cells. So not just the neurons. The alpha motor neurons is the ones which are most significantly affected when survival motor neuron protein goes deficient. So this is a busy slide which shows you about the function of the survival motor neuron protein. And there's no point in going through each and every one of them. Even producing the ribonucleoprotein, everything depends on the spinal motor neuron. Survival motor neuron protein. So what happens to the neurons? What happens to the muscle? So you can see a normal axon, how it would look like. And the axon which is affected by SMA, and the muscle also atrophy. So it is not just the neurons, the muscles as well, both become weaker. And so it's predominantly a proximal and symmetrical muscle weakness, atrophy, and paralysis. So of course, the new classification is different. We have sitters, non-sitters, and ambulant. So that is the only three way we are classifying them. And as you can see, the non-sitters, the type O and type 1 come into that category, and some of type 2 too. So even a type 2 can be a non-sitter. So this all depends on, as Dr. Ranjith mentioned about the SMN2 copy numbers, and that is the numbers which are given. And Dr. Ranjith had gone through already. I'm not going to touch on it now. The type 3, 3A and 3B. So when it is 3A, the onset is before 3 years of age, and 3B, it is onset after 3 years of age. So this is again the same slide. It just to mention about the life expectancy, how much it could be. So type 1 would be less than 2 years, and type 2 is shortened, but we don't know. It's more than 2 years. It's very difficult to say. Much depends on the management. And type 3 and type 4 have normal life expectancy, but they have muscle weakness and they have the difficulties falling, breaking themselves. So now comes to the part which I'm talking about through. So first bit of any consultation will go through with the history. So first we ask about the family history. Is there anyone who's died before? And that is a very simple thing which will give us the clue of what is going on. Consanguinity of the parents, because this is an autosomal recessive condition, and ask for reduced fetal movements. So you could sometimes get that weakness even prenatally. Some of the type 1s can, and many of the type 0s do. And so do ask for those three things, very important. And when the child is born, the child could well be normal, completely normal without any obvious abnormalities, or you can see arthrogryphosis. So when you do see arthrogryphosis, one of the important things to look out for is SMA. So do look out for that. Then you see if the child was floppy, and the floppiness can get worse over period. And next comes the important bit, which is the muscle weakness. So the child initially who's moving all four limbs quite well, gradually starts to move the lower limb much less than before. So as the baby starts becoming weaker, the lower limb just stays still and there is no anti-gravity movements at all, while the upper limb is still moving. And that would be a very typical finding in SMA. Then the other thing you need to look out is the suck. The bulbar weakness is again another area where you can find this muscle weakness. These children are more likely to get recurrent chest infections and then of course they will fail to thrive. So when you look at the clinical features, the first thing you always look at is hypotonia, a floppy infant and the decreased muscle tone. And if they have an absent deep tendon reflexes and there is some paradoxical movement in the chest wall, look, think SMA. So that is the most important thing. So any baby, you find hypotonia, sometimes when you see them at 6 weeks for the vaccinations, and immediately check for the deep tendon reflexes. If that is negative, that is not elicitable, and you see some paradoxical movement in the chest wall, hey, you need to get this tested immediately. That's a very important one. Now, diaphragm and the facial muscles are usually spared. Sometimes can have a facial muscle involvement, but it's very rare. But the eye muscles are usually completely spared. So that's the most important one to look out for. And the peripheral muscles, bulbar and intercostal muscles are most often affected. So these are things to just few points to keep in mind. If you have this in mind, you can easily pick it out. And a bell-shaped chest, look out for it. The bell-shaped chest, and you can see the comparison between a normal chest and a bell-shaped chest. This is more prone to infections, is going to run into more difficulties. Then Dr. Ranjith showed you the tongue fasciculations, which is again alpha motor neuron effect. Then if this child usually have a normal head circumference and they are bright-eyed, they have a good social smile, and also look for scoliosis and contractures. These can be present even very early. So even at 2 months, you can have some scoliosis. The contractures can be seen even at birth. So please do look out for them. So these are all giving you clues to get an early diagnosis. So how would you investigate? Well, if you do a muscle biopsy, you'll find a group atrophy. Would you advise that? No, it will be MLPA. So multiplex ligation dependent probe amplification. It is like simply putting in a small piece of the SMA gene and then picking out whether it is present or not. So this is the more detailed one. So the MLPA is the gold standard. If you look at this MLPA, this is the gold standard that you need to use to detect the number of exon 7 and 8 of the SMN1 and 2. But if you want it urgently, you can use the qPCR. This is just real-time PCR, which you can get similar to the one which we use for COVID virus. So that can also be altered to detect these mutations, and that could be accurate to 98.8%. So which would be very good. So this is what we need to keep in mind. So if you want a quick diagnosis, this is what it is. So if you don't have a deletion or mutation in the SMN1 gene, the chance of it being SMA is very, very small. So then comes the management. So the important aspect of management is early diagnosis. So we need to make the diagnosis very early on. We need to maintain the health of the child and need to prevent complications. This is the main target as far as management is concerned. So let's look at how often the diagnosis is delayed. So if you take a type 1, they usually, the presentation, like initially you start seeing it by about 2 to 2.5 months. And the diagnosis is often made at 6.3 months. So that kind of 3-month delay is significant. And when you look at type 2, it is even longer, somewhere like 12 months, nearly a year is gone before the child is diagnosed. When you take type 3, the presentation can be somewhere around 3.5 years. And then you get the diagnosis by the time they're about 4. So these are studies which show how often they are missed and how long it takes to make the diagnosis. So why should you make a diagnosis early? Because the delay will cause damage to the motor neurons, which are not going to recover, some of them. And that is going to have a direct impact on the physical aspect of the child's development, definitively. So what are the benefits of early treatment? So if you get the treatment early, then you can modify the rapid and irreversible loss of the motor neuron. That is what will happen. So we need to prevent that from happening. And the chance of survival as well as functional gains, both the aspects are enhanced. Now, it is also the key to mitigating the phenotype. So you can get a type 1, you do it properly, then we are going to get the phenotype sorted, and it is not going to be in the type 1 anymore. We might be able to get to nearly type 3. The motor milestones can be achieved, and pre-symptomatic, if someone is able to get the treatment, there is an opportunity for normal development. And that comes in a study which, this is the study of nusinersen, which is Spinraza, and that clearly demonstrates the top 2 are the ones which are the nurture study, starting treatment of nusinersen in pre-symptomatic. So the ones who are probably siblings are picked out early before they even develop the symptoms and the medicine is started. And this is the kind of response. Nearly the maximum score of 26 can even be achieved in that situation. While the ones who were diagnosed and then treatment was started, this is where they were achieving. The scores maximum were getting about 13 to 14. And the last 2, the NDA ones, are controls. And you can see that if you don't treat them, this is what happens. And that is all their survival too. So this tells you very clearly the outcomes can be so different just by making an early diagnosis. And that is why early diagnosis is essential. So what are the therapeutic targets? So the therapeutic targets are 1. So you have the 6 and 8 exons, and 7 is the one which goes away in SMN2 because it's a faulty one. And because of that, you get the low levels of survival motor neuron protein. Now, what can be done is when you use antisense oligonucleotide and splicing modifiers, you can splice the SMN2 in such a way that 7 stays there. If 7 stays there, you are going to produce a much higher amount of survival motor neuron protein, and that will enhance the lifestyle so much. So that is what you can see here, how it can break properly and then get you the protein. And the other one is Zolgensma, which is the SMN1 gene replacement using the adenovirus vector, adenovirus associated vector. And that one would replace the gene. So I will go through into the next slide on that. So the SMN1 gene replacement therapy, where that gene is put in a virus, introduced into the cell, and that corrected SMN1 gene is replaced. So that is considered just one-off treatment with just one IV infusion for over 1 hour. And there is still a lot more to learn because we're in the early stages, and people have found it very useful. Now, the SMN2 gene transcription, you can see how effectively what the spliceosomes should do is to take the introns out so that the exon 6, 7, and 8 stays together, and then you get a good amount of survival motor neuron protein. But if you look here, when these spliceosomes cut through these introns, it removes the exon 7 as well together. And that is the problem with the normal SMN2 gene not being able to produce adequate amount of survival motor neuron protein. So this is what can be altered by the medicines risdiplam and nusinersen. So I've gone through this slide. So this is the findings of the different nurture and NDA studies. Now looking at Zolgensma, when they use Zolgensma and when they look at the ones who haven't had the treatment, the controls, you can see the survival difference. By about 14 months, you can see most of the Zolgensma ones were alive, while very few of them, less than 30% were alive who were controls. So this is a significant result. Then when you look at the risdiplam, which is similar to nusinersen, but the biggest advantage with this is it can be an oral treatment. It is just an oral one. So nusinersen has to go into the intrathecal one. So it has to be every 3 months you have to give a intrathecal LP injection, and then that is how it works. But risdiplam is just an oral treatment you can take once daily. It is approved in India. The ease of administration is so impressive. And of course, the fish studies which are clarifying it will be in the next presentation. So I'm not going to touch on it. Next thing they are doing is about the newborn screening, which I don't see coming into India soon because we don't have the treatment options available for everyone. But Germany, they are doing it. And what they are finding is if they find it in the newborn period itself, it would decrease the cost of support needed and the functional impairment would be much, much less. So because 90% of neurons are affected by the time they are 6 months of age. So when you come to the rest of the management, so that is the genetic management which I have gone through. So the next bit is multidisciplinary. So you need to get the pediatric neurologist or pediatrician, geneticist, physiotherapist, orthopedics, respiratory, gastro, dietitian, and a speech therapist. The whole team has to work together to get children with the SMA sorted. So let's take the gastro bit first. It's interesting that they will have a significant failure to thrive initially. But then after that, obesity becomes a problem, particularly owing to the lack of activity. And then you have a gastric nasoduodenal tube or even a gastrostomy. The other problem they come across is gastroesophageal reflux, which affects their causes recurrent aspirations. You can also have problems with swallowing and again aspiration that needs to be monitored. Sometimes they need a gastrostomy. The diet has to be monitored to make sure that they get adequate amount of calories. At the same time, it shouldn't be too much for their activity because they will put weight on and that will make things worse. And the other thing which can also happen is sometimes you can have acidosis, hypoglycemia, hyperglycemia, hyperlipidemia. All these things can happen with the SMA. So don't say it is not SMA because we've got an acidosis or a hypoglycemia, because this SMN protein is necessary for so many aspects of cells that even this has been a presentation at times with SMA. So hypertonia, if you have this acidosis, absent deep tendon reflexes, do go looking for SMA. Still do the gene, please do. The next one is with orthopedics, where you can develop scoliosis, and SMA 260 to 90% will have scoliosis. And if it is about 15 to 20%, you can monitor. More than 15%, they would probably need braces, and more than 50% will need surgery. And when you're using rigid braces in SMA1, you have to be very careful that respiratory function is not compromised. We can run into difficulties. The surgical intervention is usually after 4 years. So the contractures develop, look for it. If you're looking for it, where you would get it most often in the lower limb would be the knees first. So the knees first, and then the hips, and then the ankle. So knees is likely where you will see the contractures developing in the lower limb. And similarly in the upper limb, it will be the elbows. So for some reason, those are the two joints which are really where the contractures develop. Bone health is very important to maintain. You need to check calcium, vitamin D, the bone profile, and DEXA scan will be necessary. The most common problem would be the pulmonary one, because that is what takes the life. So they usually present with recurrent chest infections and a weak cough. And you can see the intercostal muscles are quite weak. So the diaphragmatic breathing is happening, and the gastroesophageal reflex, which causes aspiration. And you have the scoliosis, and then they also have the nocturnal hyperventilation. Put them all together, we are in big trouble with the pulmonary aspect. So it is a very, very important aspect of management, and that needs to be monitored very closely. 6 months is what is suggested, but it should be more frequently than that. It's very important these children are vaccinated. Both pneumococcus and flu vaccines should be given. And this is the quick list of the differential diagnosis. I don't want to take too much of time. I've Been given 20 minutes. I'll try to stick to this. So congenital myasthenic syndrome and carbohydrate metabolism disorders like POMPs, congenital muscular dystrophy, and congenital myopathies can look like this. So you need to keep in mind, but still look for SMA first. The important take-home points here is early diagnosis is essential because that would improve outcome with gene therapy. So if you see a child with hypotonia, absent reflexes in an infant, go for the specific gene testing, do an MLPA, or if you can at least get a PCR, if that is possible. So that is what is important. So always go for it straight away. Don't hesitate. The other tests can wait. And once we have the diagnosis, you have to involve a multidisciplinary team, even after we have given gene therapy, because that is not the ultimate answer. So we really need to make sure that the team is involved very early on. So I'll take questions at the end of the session. Thank you very much.
Thank you, Dr. Velmurugan, for your nice presentation regarding clinical diagnosis of SMA. Now I welcome Dr. Manaswini Suramakrishnan, Chief Operating Officer, Tamil Nadu and Puducherry, Roche Products India Private Limited, for talk on disease-modifying therapies for SMA treatment. I welcome Dr. Manaswini.
Thank you, Dr. Rajendran. Thank you for inviting us to present today. And thank you, Dr. Ranjith, as well as thank you, Dr. Velmurugan, for your presentations. So I will start just with a brief intro about the modifying therapies, which Dr. Velmurugan already covered, and then share about some of the data that we have with risdiplam or Evrysdi. So with the SMA, because of the root cause of the disease is actually lack of SMN protein. There are two ways to treat SMA now, which was not possible 5 or 6 years ago. So there is the gene replacement therapy, which is replacing the SMN1 gene, or we can target the SMN2 gene and then look at the alternative splicing in order to include exon 7. So both these methods are viable, and they are usually clubbed as disease-modifying therapies because it addresses the restoration of SMN protein. Now, I will go specifically to risdiplam or Evrysdi data. So this is the only DCGI-approved disease-modifying therapy that's available in India. So we've been through the regulatory approval with the DCGI, and how it works or what it is. So it is oral, like it was mentioned in the earlier session, and it's extremely selective. So it is selective only to SMN2. So it binds to SMN2 exon 7 and allows for the exon 7 to be included. So it produces full-length SMN2 mRNA, and it also produces functional SMN protein. And it's available everywhere. So it can go into the motor neurons, and it can also go into the tissues, and it penetrates the blood-brain barrier. So this is the mechanism of action that's illustrated. So where here is the molecule, and that binds to, there are two sites that it binds to. So the exon splicing enhancer 2, which is present within the exon 7 of SMN2 mRNA, and it also binds to the 5' splice site. And because of this, it produces the full-length SMN2 mRNA and starts to produce SMN protein as soon as it's given. And this is important from a blood-brain barrier perspective because some of the other disease-modifying therapies do not go everywhere. So, for example, nusinersen was presented before. So it is given intrathecally, and it's because it's only present within the CNS and the spinal cord. If you were to administer an antisense oligonucleotide in the periphery, in the blood, for example, it will not move to the motor neurons, which is why oral was important to develop. And we developed Evrysdi in the same lab or the expert which also developed the nusinersen. So the unmet need that was found was not to have an intrathecal injection and to have a better mechanism of or route of administration. So what has the molecule been studied? So it's been studied across multiple different population, SMA population. So we have the rainbow fish, which is the pre-symptomatic SMA. So the nurture trial that was shown before, so this is the same population. So from birth to 6 weeks old. And what we have looked at is efficacy and safety. And then risdiplam is also studied in firefish, which is type 1 SMA babies. So they are symptomatic by now. So they have clinical manifestation of the disease. And they were 1 to 7 months old. And this study was done in 2 parts. Part 1 was looking at the dose finding, and part 2 was looking at efficacy as well as the safety. And then sunfish, which are type 2 and type 3 SMA. So there are children who were 2 years old, and there were adults up to 25 years old that were included within the study. And this was also done in 2 parts. So part 1 was dose finding, and part 2 was efficacy and safety. And this is one of the largest trials that has actually happened in SMA space. And jewelfish is a very, very interesting study. So this is a non-naive patient. So meaning SMA children and teens and adults who have previously been treated with a disease-modifying therapy or any therapy that was available for SMA. So including, the gene therapy, including nusinersen. So the age group was 6 months to 60 years old. So they've all had a previous treatment. And we've looked at PK/PD as well as safety within this population, as well as there is exploratory endpoint of motor function assessment. So we'll start with rainbow fish today. So this is the pre-symptomatic population. So the inclusion criteria for this was the patients need to be 5q SMA, and they are newborn. So this was before they present any clinical signs or symptoms of the disease. So this was up to 6 weeks after the birth of the child. And they've been treated today for already a year, and they're continuing to be on the study. So the primary endpoint is sitting without support. And this is based on the Bailey scale, gross motor scale, item 22. And then there are several secondary endpoints as well that have been assessed. So when do they develop a clinically manifested SMA, if they do, because they're on a disease-modifying therapy? Survival and permanent ventilation, achievement of motor milestones, so that a normal baby would do, like sitting, crawling, head control. CHOP Intense Goal, which is a motor function assessment. Growth measures, how are they developing with their percentile for a baby. Ability to swallow and feed orally, which is very important from a quality of life standpoint, and also children who are type 1 SMA, they do lose their ability to swallow very quickly. So bulbar function is measured, as well as CMAP and PK/PD as well as safety. So this study is extremely important because this shows the importance of intervening early. The sooner we offer a disease-modifying therapy, the better it is for these children. So they need to be on some therapy or the other ASAP. Here, the age at first dose, so they were roughly around a month old. So these babies were 28.5 on a median. So the youngest baby was as small as 16 days old. So from a copy number, so there was severe type 1. So with 2 copy numbers, there were 5 of them, and over 2, there were 7. Gender, male and female. And SMA identification method was both. One was, if there was a previous child, so there was a family history, or knowing that the mother and the father are carriers, or newborn screening. In some countries around the world, newborn screening has now been mandated as soon as the babies are born. So these are the results. So if you actually, there are no head-to-head trials, but you would compare them with results from the nurture study that was shown, as well as START, both in pre-symptomatic population. So it shows that most of the infants are actually developing according to WHO standards for healthy children. So all of them can maintain head control, they can sit, they can roll, they can crawl, and 80% of them are standing without support, 20% stand with support, and 80% of them are also walking independently, and 20% can bounce. And this data is very, very new, meaning we presented this at the International Congress just 3 or 4 months ago. So it's going extremely well. And most of the, so this is again the different kind of representation of the previous chart, where most of the children are developing like a non-SMA child, like a healthy child. And this is the CHOP intent score, which is the motor function assessment. So a maximum score that a non-SMA child, like a healthy child, can reach is 64. And as you can see, the ceiling, so many of the children have actually gone into 64. So for an SMA child who does not get a therapy, they will not even reach 40. So here in this data, so every one of them has actually reached 58 and more, with majority of the population reaching the ceiling. And in terms of the adverse events, so risdiplam is actually very, very safe. So no one has discontinued from the trial in any of our trials due to the administration of the molecule, because of the molecule. And the adverse events that are seen are more of the disease itself, SMA, as well as the events that you would see as a pediatrician even, or a child who's developing the first 1 year, like teething. So nothing was related to the drug per se, and all of them are continuing. So just to summarize, so there's been, most of the infants are achieving motor milestones, and they have been on treatment for over a year, and they reach the maximum score of 64 on the CHOP intent. There's been no treatment-related adverse events that has led to discontinuation. And this will still be ongoing, because the current label that we have is for 2 months old and older patients, so all types of SMA. So this trial is very critical to get that 0 to 2 month old children the therapy that they deserve. And quickly, before I go to the firefish, we often get questioned in terms of how do you compare, like what does it actually mean between the disease modifying therapies? So there is no head-to-head trial comparison, but there is, of course, clinical trial data as well as real-world evidence. And currently across the globe, there are over 4,000 patients who are actually getting risdiplam as of today. So this is between the molecules. So we've got, different categories. There is the 0 to 2 year old, the really young patients, and then there is the 3 to 17 year old and the 18 plus, adults. So between the three, of course, gene therapy is only indicated until 2 years with the FDA. So nusinersen has also been indicated, and risdiplam works as well in 0 to 2 years. I think the plus is indicative of, especially with nusinersen, there's a lesser plus because of the route of administration and the adverse events that have been seen because of the intrathecal mode of delivery. From a 3 to 17 year old, from a trial perspective, there is no data from gene therapy. And from a nusinersen, there's data from to 9 years old within the trial setting, but there's real world evidence for kids who are over 9 years. And then for risdiplam, we've had data until 25 and of course 60 years from jewelfish. And 18 plus as well. So from a trial perspective, very well covered. From real world evidence, we have some data from nusinersen, whereas gene therapy, there isn't a data both in trial as well as real world setting so far. So from an administration, so it's been mentioned before, so it's oral and it's daily dosing at an everyday. There's intrathecal, which sort of gives a little bit of a pain from an ASO administration. And gene therapy has an advantage as well, where it's only one time. You cannot administer the adenovirus vector a second time. So you can only do it one time, and that provides the benefit. From a safety tolerability perspective, so they all do fairly okay. There is a black box warning for gene therapy due to risk of liver injury. And I think you might have also noticed, especially in India, there have been a couple of gene therapy kids who have passed away after getting the therapy. It's much more to do with also late intervention. So the negative advantage or negative situation that we're seeing right now are babies are need to wait to try and access the gene therapy, and because of which the disease progresses in that time period. So they really need to be in a disease modifying therapy as soon as possible, as early intervention is key. In terms of sustainability of effect, so how much is the duration of the effect that's being seen? So it's everyday dosing that risdiplam has. So SMN protein starts to build up as soon as day 1 of administration, and it reaches saturation level or reaches twofold and more, a steady state at 4 weeks, and it continues to maintain there. So there was a recent publication according to nusinersen, according to a German group, where there is a slump that's actually seen between nusinersen doses. And they've now initiated a trial called DEVOTE to increase the dosing of nusinersen. So the sustainability of effect is still being worked on. And then with gene therapy, there are several kids, also 2 of them in India, who have got gene therapy, who have now followed on to get Evrysdi. So the long-term effects, so it's not a cure. They don't need intervention after the AAV virus has been administered. So in terms of availability throughout the CNS and peripheral tissues, so risdiplam crosses everywhere. Nusinersen is present in the CNS, and gene therapy is also present everywhere. And from a breadth of data package, so from a clinical trial perspective, the largest study that has been conducted across the world was with Evrysdi. So nusinersen has a wealth of data, especially from real world. So they were approved by the FDA in 2016. So both these molecules are not available in India, can only be imported. And there's a small number of patients who have been getting the gene therapy due to the affordability factor that goes with it. From a familiarity of scale, so this is another question that's often asked. So which scale should one look at from a motor function assessment? So there are 2 scales, so MFM32 and Hammersmith, which is the HFMSE. So there is low familiarity of MFM, but this has started to build up, especially in Europe and the US. And HFMSE is widely used. And so both can be used depending on the population that you'd look at. And in terms of number of patients who've been treated, so there are over 4,000 patients with risdiplam. There are about 11,000 patients on nusinersen, about 2,000 a year. And there are about 1,200 patients on a gene therapy, and they've been approved for about 3 years now. So the next study, which was symptomatic patients that we were looking at, is Firefish. So it was done in 2 parts. So one was the dose, and the pivotal study was actually part 2. So the inclusion criteria was 2 SMN2 gene copies, and the babies were symptomatic. So they had already started manifesting the disease. And the primary endpoints for part 2 was sitting without support. And there were also a string of secondary endpoints that I'll just go through now. So this is Firefish part 2 study. So this is, the left is 12-month data. So 1 year after treatment with risdiplam, and then 24-month data. So what happened to the same babies at 2 years? So there was 29% of the infants who can sit without support for 5 seconds and more. And this had improved to 61% of the same population who were sitting without support for at least 5 seconds. Now, this is momentous because if you compare it to the natural history, so for those kids who have never had a therapy, they will never reach these milestones as independent sitting or rolling. And then we also looked at 30 seconds sitting without support. So at 12 months, 17% of them can sit without support for at least 30 seconds. And there were 44%. So nearly half of these patients could sit without support for 30 seconds and more. And then we were looking at the Heine scale. So head control, sitting, standing, and walking. So the light graph here is the 12-month data. And the dark blue graph is the 24-month data, where when 76% of them could control their head after 12 months of therapy, 83% of them could do it at 2 years. 61% of them could sit at any level with and without support at 12 months, and 71% could do it over 2 years. And standing without support, there was 22% with or without support. And in 2 years, there were 27%. And 2% of them were walking in 2 years, which was 4% at 2-year data. And this is very, very critical. I think Dr. Ranjith as well as Dr. Velmurugan covered this. So swallowing and feeding ability. So bulbar function is often lost in these patients when they don't get a treatment. And this was measured in our clinical trial. An interesting trivia is, so we never included this as one of the endpoints, So when the trials began a few years ago, the principal investigators actually contacted us to look at bulbar function as a endpoint, because they were already treating with these other disease-modifying therapies like nusinersen or even the gene therapy. And they were seeing a remarked effect on bulbar function, particularly with risdiplam. And that's how we started measuring it. So 92% of them were able to feed orally. So this is at 2 years. And 95% of them maintained their swallowing ability. So they could actually eat independently. And compared to a natural history, you know, all the infants who survive beyond 12 months, 100% of them will actually need feeding support. So a gastric tube or a nasogastric tube. And we also looked at event-free survival. So event here is actually defined as death or need for permanent ventilation. So 83% of the infants at 2 years were event-free. Again, compared to the natural history data at 24 months, almost all of them would have either needed a permanent ventilation or would have passed away. And then looking at the CHOP intent score, so 40 is of relevance here because the SMA children cannot usually reach 40 as a score. So looking at the 2-year data, the dark blue graph, so over 76% of them were over 40 and above, 44% of them can reach 50 and above, and 10% of them could actually reach even more than 60, and 64 being the highest score that they can achieve. And this is also another factor that we've actually heard, even from patients in India who've actually received the drug, significantly reduce the number of hospitalization that is needed. So in 12 months, so the hospitalization per patient per year was 1.3. So they only visited the hospital just once, or 1.3, you know, not even 2 times per year. And it's decreased to less than once in 24 months. And out of the population, 34% of them did not require hospitalization even once over the 2 years. And from adverse events, very similar to the rainbow fish, so it was representative of the underlying disease. So there were no treatment-related discontinuation in the trials. And risdiplam has been approved by the FDA, EMA, as well as DCGI for children over 2 months and older and across all types of SMA. So Sunfish was another pivotal study. So this was also done in 2 parts. So part 1 was dose finding and part 2 was safety as well as efficacy. And this was in children who were type 2 or type 3, ambulatory as well as non-ambulatory patients, and they were 2 to 25 years old. So this is the primary endpoint that we looked at. So change in MFM32 score. So we used MFM32 because the kind of patients who were actually included here, we also had severe patients with severe scoliosis, over 40-degree curvature. So we used MFM32 because it has 3 domains that it can measure. So as you can see here, the blue is the risdiplam data, and it was compared with a placebo. And look at the placebo arm. So the motor function continues to decline, 12 months and now at 24 months as well. And risdiplam arm continues to increase and stabilize as well. And then we looked at the revised upper limb module. So this is important, especially for the non-ambulatory patients, as to how well they can move their upper limbs. And the blue data is on risdiplam, where continues to increase compared to the placebo arm, which shows decrease within the RULM score. And then we looked at the score RULM baseline. So one point to note here is that placebo arm was only given placebo until 12 months. So they moved over. So they were then given the drug after 12 months, so which is what is shown here. So until 12 months, you can see the comparison against the placebo arm. And post 12 months, the risdiplam arm is mentioned, which continues to improve in terms of the RULM function. And from a safety aspect, so no drug-related AEs. There have been no, that led to treatment withdrawal. And there have been only AEs which are indicative of the underlying disease. So the most common ones being, upper respiratory tract infection, which is quite often seen in SMA, nasopharyngitis, pneumonia, So there are 100% survival of these patients, and they've also had no drug-related findings, as I mentioned earlier, that led to treatment withdrawal. So summarizing, so MFM32 as well as RULM score showed significant improvement versus placebo, and there are 24-month data available where they continue to increase as well. So there was a novel endpoint that we actually introduced called SMA-IS, which is SMA Independent Scale. So this was a survey that was filled by patients and caregivers on how the drug affects their activities of daily living, like brushing their teeth or eating food independently, taking a spoon to their mouth. And this showed a significant increase as well from a caregiver perspective. And there have been no treatment-related withdrawal. So this was the pivotal study that allowed us to get approval, DCGI, FDA, as well as EMA for type 2 and type 3 patients. And then finally, jewelfish. So we'll close with the most interesting one. So these are patients, the inclusion criteria was 5Q SMA diagnosis. So age 6 months to 60 years. I think the differentiating aspect here is they are non-treatment naive patients. So they have previously been treated with, so there was another splicing modifier called RG7800. So they were allowed to come on risdiplam. Of course, nusinersen that we have heard about in this session as well. Olazoxime, which is a neuronal protector, not a disease-modifying therapy, as well as the gene therapy that makes the rounds and news, especially in Tamil Nadu recently. So they were all able to move to risdiplam, and we've had the 12-month interim analysis data. So the primary endpoint is safety and PK, and the PK-PD relationship, especially with SMN protein. Can we actually increase SMN proteins on those patients who have previously even received another therapy? And we've also looked at the motor function assessment through MFM32. So this is a busy slide. The take-home message here is age of enrollment. There is a spectrum of age. It ranges from, so the lowest you've got like 1-year-old, there's a 60-year-old, gender, male and female. So type, it was across 1, 2, and 3. SMN2 copy numbers, so it's up to 4 copy numbers, and there's one where we haven't been able to identify. From a motor function assessment, so between non-sitters, sitters, and walker, there's representation across the board. HFMSE, so Hammersmith baseline score, which was less than 10. Yes, we have them included, as well as patients with severe scoliosis and over 40-degree curvature, and patients who've had a hip dislocation. And what were the primary reasons to come from another therapy? So the top one is around nusinersen. So there were treatment-related tolerability concerns, which were the majority of them. There was lack of efficacy from the treatment. There was loss of efficacy from the treatment, as well as caregiver or patient preference to move over to risdiplam. And from the gene therapy, so there's been hopes of additional benefit. So it was a clinical need, caregiver preference, as well as a lack of efficacy in terms of the treatment response. So from continuation, so 5% of them have discontinued. All of them from the gene therapy are still continuing. So mostly related to withdrawal by subject. From a treatment perspective, so there has been no treatment-related safety findings. So all of them are continuing, and there has been no withdrawals due to the use of risdiplam per se. And again, the adverse events and serious adverse events were reflective of the underlying disease. So there's again nasopharyngitis that comes up, pneumonia, LRTI, lower respiratory tract infection, upper respiratory tract infection. And then this was a very interesting result that ourselves were looking forward to seeing. So this was the PK-PD data, especially with SMN protein levels. So the question was, especially in populations such as those who are treated with gene therapy, where there is, it's been said that there is a long duration of response. Is it possible for another disease-modifying therapy like risdiplam to actually increase SMN protein level? Is there even a need? And similarly for the other disease-modifying therapies as well that were included within these populations, like nusinersen. So we found that across the board, risdiplam could still increase SMN protein, starts to work on day 0, and within 4 weeks reaches twofold and more of SMN protein levels, and it continues to stay. So, which is why there is a KOL from Italy who often says that Evrysdi causes rapid and sustained levels of SMN protein throughout. And it's available across the systems, right? So when there is a need in bone, when there is a need in vasculature, when there is a need in muscle, SMN protein is always present. And in terms of the MFM32, so this was jewelfish data from 2 to 60-year-old, a wide variety of age group, meaning, 60-year-olds, so this patient has been with the disease for a very long time. So use within this population has shown the maintenance or stabilization of the disease. So finally, just to complete here, this population has been broad and heterogeneous, and there have been patients who have actually come from other therapies for SMA, including gene therapy and nusinersen and a previous splicing modifier. And there have been no treatment-related adverse events that led to the discontinuation of treatment, and this film shows a sustained twofold increase in SMN protein levels. And we will continue to provide updates on this with every year. So there's an interim efficacy endpoint of MFM32 that has been already read out, where it shows stabilization of the disease. So with that, I thank you, the organizing committee, and back to the panel for any questions.
Thank you, Dr. Manaswini. I think it's a nice presentation, and now it's questions to Dr. Ranjith. Since SMA is of genetic origin, can pre-marriage counseling can help prevent this disease, Dr. Ranjith? Dr. Ranjith? Dr. Ranjith is available? Yeah.
Okay.
So otherwise,
maybe I can just start on.
Yeah.
The pre-marriage counseling, I think we'll go to a stage when we'll be able to check out who are the carriers and then whether we'll be able to pick them out. But definitely not something which you would even consider at the moment in India, because they find out only later. And
yeah, I am there.
Hopefully, people will start.
Hello.
Yeah.
I am there, sir.
Oh, sorry. Go on. Sorry, Ranjith.
What is the question, sir?
The question is, can you do pre-marriage counseling for SMA carriers?
How do you do? What is the question, sir?
Since SMA is of genetic origin, can pre-marriage counseling can help prevent this disease?
Yes, sir, definitely, sir. If the couple or the prospective couple is willing to go for counseling, definitely we should provide a detailed counseling. Actually, nowadays in Western countries, they are actually planning carrier testing before marriage, even in those who don't have family history. So premarital carrier testing, not only for SMA, even for other diseases like cystic fibrosis, other genetic conditions are coming up. So if a prospective couple is willing to come and they are seeking for a genetic counseling, we should definitely provide that.
But
and
Ranjith,
it can help. It can help.
But Ranjith, they have children before they get married. So
What, sir?
In the Western countries, they have children before they get married. So
Okay.
it's very difficult for you to do all those things there. And the ones who are all quite aware will marry and then have the children. They would know what they are looking at. But the group where we are likely to get SMA are unlikely to get themselves tested. That's how it is going to be. It has to come from the families.
Yeah, next question to Dr. Velmurugan. How early diagnosis can help mitigate the risk of this problem, and how will have better outcomes for long life for the patients?
Yeah, I have gone through this in the slide, because if we do pick them up very, very early, and that's why I'm insisting that if you do come across a child who's hypertonic with absent deep tendon reflexes, go for the test straight away. Because if we do get the test done early and we make the diagnosis, then the genetic treatments are there, and you can see with all the risdiplam as well as with nusinersen, you get very, very good outcomes if they are treated before they even develop all the symptoms. But even when they develop the symptoms, as soon as we get them on, if we get on with the treatment, it is going to be very effective. The second thing is also the complications are not going to develop, and those children are more likely to be mobile in the future. So all the care that might be needed later would be significantly reduced as well.
Next question to Dr. Velmurugan. Newborn screening is available internationally, but in India, it is still not adopted for certain reasons. What is your thoughts on this?
The main reason it's not being adopted here is the whole idea of newborn screening is you should be able to treat. And the treatment is very, very expensive. And once it becomes cheap, that is something people would consider. So like you do a PCR for COVID, we would be able to do it on all babies, so which would be possible. But the main issue is treatment. If you make the diagnosis and don't treat, or not able to treat, where will we go? And that is the main point which is holding us back now. And hopefully the things will become cheaper and people would become more aware, and then all these will develop, which would be excellent.
Okay, next question to Dr. Ranjith Kumar. What are the misconceptions about the 16 crore drug, which is recently making a lot of noise in the media? Any thoughts about that?
Definitely, sir. So I'm sure Dr. Manaswini would have explained in detail. So there is a lot of hype and hoopla about this 16 crore injection, and mainstream media also, we are getting too much of attention. But I think one should understand that this is a kind of a therapy which is coming up. We need a lot of long-term data, safety data in a country like India, which has huge diverse population. So it is also a viral vector. So two primary concerns are what will be the long-term data, including their sustained efficacy, future motor developments, and safety issues. And ethically also, we need to have a lot of standards. So these are some of the concerns of such treatments. I'm sure time and the future will reveal more information in this regard.
Next question to Dr. Ranjith. Considering Risdiplam is the only drug that is available in India and approved by DCGI and is highly efficacious as per records, should we even be encouraging imported treatments that come at an exorbitant cost? Is it necessary?
I think they are asking about the availability of Risdiplam. Is that the question, sir? Is he asking?
Yeah. Availability, and is it necessary to other imported drugs? Is it necessary, or we can manage with the Risdiplam?
Right now, it has been approved by DGCI, and Roche is able to provide with a formal prescription from a pediatric neurologist. So I don't think the parents need to go to the ordeal of going through import duties and all. So it is, I think they will take care. So it is available in India. We have given prescriptions, and one of our SMA type 3 patient has done a crowdfunding, and he has crossed nearly 45 lakhs rupees. And in very soon, he is going to get the drug, oral Risdiplam. The main advantage of this drug is it's an orally administrable drug. And easily administration is very easy, monitoring can be easy, and the biggest advantage is it can be given for any type of SMA, starting from type 1 to type 4. So the presence of scoliosis or other orthopedic complications which negates the use of nusinersen is not there with Risdiplam. So it can be given for those even who are in wheelchair bound with scoliosis. At least it will prevent the relentless progression of the disease. So definitely this drug will help. It's a easier alternative for administration. We understand the cost is high, which extensive use and future developments, the cost may come down.
Dr. Ranjith, do you have any records how many SMA children are in Tamil Nadu?
Any data of how many children, sir?
Yeah.
No, sir, I don't. I am working in a private university, so we don't have any exact data of that. But in my practice, I do see one case on an average per month, ranging from type 1 to type 4. See, I am working closely with adult neurology department also. I do get referrals from them also. So there are so many cases of undiagnosed type 3 and type 4 in our country. So they can also benefit from these drugs like risdiplam. It's not only the children who will benefit. Even the adults and adolescents who have SMA can benefit. I don't have the data. It is a need of the hour to do a study on the demographics of SMA in our state.
Chandramali, do you have any data?
Maybe Milan, I think Dr. Milan is there. I think he'll be the person who can just probably comment upon this particular things. Dr. Milan?
Yeah, sorry, can please repeat the question?
How many SMA children in Tamil Nadu? Do you have any data?
Oh, in Tamil Nadu, we should be having. Are you asking for the prevalence rate of SMA children in Tamil Nadu or the kids on risdiplam?
Totally, how many SMA children in Tamil Nadu?
It should be around 800, 900 kids based on the prevalence data, right? Because it's 1 in 100,000 people of population, right? So if we consider about 9 crores of Tamil Nadu population, that should translate to about 800 to 900 kids. Yeah. Actually, sir, it is on similar lines to hemophilia A. If you look at the prevalence rate of hemophilia A, that is also 1 in 100,000 people, right? So based on that, we can draw some parallels. Yeah.
Okay. Yeah. Dr. Jalil Ahmad, you want to tell him? Unmute. Unmute.
Sir, you can unmute, sir. Yeah.
I just wanted to share 1 or 2 minutes. That was a wonderful talk by all the 3 speakers, and Velmurugan has highlighted the clinical presentation. And it is to Ranjith and then the madam. You have mentioned about these 2 drugs, and these drugs are disease modifying drugs. And in one slide, you have mentioned about it is a type specific drug. And Dr. Ranjith mentioned it can be given for all the types of, that is, risdiplam must be given for all the types. Is it, what is your comment on that? Because of the non-availability, or we can give it for all type of SMA? And the second question is, the pre-martial counseling can be done for an at-risk couple?
Dr. Manaswini, I think you should answer the first question. I will answer the second question.
Okay, Dr. Ranjith. Hello, Dr. Jalil. Thank you for your question. Yes, so risdiplam can be used across all the types of SMA. Not only because of it being available in India, it's actually indicated across. Because it works on the SMN2 copy number. And to Dr. Rajendran's earlier question, so we think there are about 90 to 100 currently in Tamil Nadu who have, because it's also, we need to understand that type 1, they will pass away if they don't get the treatment. So even though the prevalence data from literature might be higher, so we hope that, to what Dr. Srinivasan said at the beginning of the presentation, that there is access to it through the NHM route. Yeah, so with that, I will pass it on to Dr. Ranjith.
Thank you, Dr. Manaswini, for clarifying that it can be given for all the spectrum. Sir, that's a very good question. So American College of Medical Genetics defines at-risk couple as those who have already previously had a confirmed case of SMA, either multiple or a single case, those who have had a suspected case of SMA but not genetically proven, and those who are known high risk of carrier status in their family. So these are some of the high risk couple. So definitely we should offer genetic counseling, carrier testing for these couple, and we should assess the risk, and we should also explain there is a chance of detection in utero and the possibility of even pre-implantation genetics has come. So we should definitely go for carrier testing in at-risk couple. but we have some ethical principles involved in our country, like cultural practices across religions and including the ethical practices. So, and we should also respect the autonomy of the patient. Only one thing which is cropping up is now that with the availability of newer medicines, with the fetus being affected, the couple has to take the decision about the continuation or termination of pregnancy accordingly.
Thank you, Dr. Ranjith. Now it's a time to give vote of thanks. Now I invite Mr. Chandramouli to give vote of thanks.
So thank you, sir. Thank you, doctors. In fact, I would once again thank IAP on behalf of Roche. I would like to thank IAP for giving us an opportunity to present this particular topic on spinal muscular atrophy. And I would like to thank Rajendran sir because he has, we know, like it has really been, of course, we have taken time and moreover, like it has been very kind enough, Dr. Rajendran sir, to give us this particular platform. And in fact, other members of IAP team, Dr. Jalil, Dr. Ismail, and of course, other doctors who have been there with IAP. And in fact, I would like to thank the speakers, Dr. Ranjith from Ramachandra Hospital, Dr. S. Velmurugan sir from GKNM Hospital, and of course, our COO, Dr. Manasni, who has been spending their valuable time to present the slides on SMA. And of course, our doctor from Mumbai, Dr. Milan, and of course, other doctors who have been there. So thank you, sir, for having this session. And it's been a wonderful time for all of us. And I'm sure like we all have learned a lot of insights about spinal muscular atrophy and also some of the recent advancements in spinal muscular. Thank you so much. Thank you, doctor.
Thank you. Thank you. Thank you, Ananda.
Thank you, sir. Thank you.
Thank you. Good evening.
Thanks, sir. Thanks.
Thanks.